because limited of the time, we will move to the second topic. The second topic is neuroblastoma imaging, cutting-edge clinical advances, will be presented by Dr. Thipsumon, Tangsiwong, and now she is an instructor at the Puttachinnarat Pisanulok Hospital. Please welcome Dr. Thipsumon, please.
Good afternoon, everyone. Thank you, Ajahn Supika, for that kind introduction. I'm truly honored to be here today as a guest speaker at this conference. I appreciate this opportunity to share my insights with such a distinguished audience. Today, I'll be discussing an important aspect about neuroblastoma imaging. Neuroblastoma is a complex disease, and accurate imaging plays a crucial role in diagnosis, staging, and treatment planning. I hope this presentation will provide valuable insights and spark meaningful discussion. Once again, thank you for having me, and let's begin. I have no conflict of interest in relation to this presentation. Today, I'll talk about 4 main topics related to neuroblastoma imaging. These include diagnosis, staging, response assessment, and follow-up. Neuroblastoma is the most common extracranial solid malignancy in children and the third most common pediatric neoplasm behind only leukemia and brain tumors. It arises from primitive cells of the sympathetic nervous system. So, the tumor can develop anywhere along the sympathetic chain, but most cases are found in the adrenal glands, followed by retroperitoneum and the chest. About 90% of neuroblastoma occur in children aged 5 years or younger, and clinical presentation can vary from spontaneous remission to aggressive progression. Now, let's talk about how the diagnosis of neuroblastoma is made. The diagnosis of neuroblastoma starts with history taking, physical examination, and laboratory tests, followed by imaging and pathological confirmation. For imaging, we typically begin with radiographs and ultrasound for initial evaluation. CT, MRI, and functional imaging such as MIBG and PET scans provide more information to help with staging and assessing metastasis. Common radiographic findings in neuroblastoma include a soft tissue mass, almost always with calcification, as well as paraspinal soft tissue lesion and bone erosion or destruction. This chest radiograph reveals a large calcified soft tissue mass over the left upper abdomen and also soft tissue bulge on the right side of the thoracoabdominal region. These tumors are typical features of multifocal neuroblastoma. Another patient, this is a shoulder radiograph showing a moth-eaten osteolytic lesion with focal cortical destruction in the proximal humerus, is consistent with bone metastasis. Ultrasound helps determine the size, location, and characteristic of the tumors, especially in the abdomen, and is useful for guiding further investigation as well. This sonographic image shows a large calcified soft tissue mass in the right suprarenal region, a typical finding of neuroblastoma. Shifting our focus to compare CT and MRI for staging neuroblastoma. Currently, there's no consensus about the optimal imaging modality for assessing local disease, as both have advantages and limitations. In summary, CT is fast, widely available, and excellent for calcification and general staging, while MRI provides better soft tissue contrast and avoids radiation, but takes longer and often requires sedation. The choice depends on clinical context, resources, and patient needs. Now, let's move on to the cases. starting with CT and MRI images of a neuroblastoma patient presenting with intraspinal disease. The MRI provides better visualization of the tumor. However, we can clearly depict a left paraspinal soft tissue lesion extending into the spinal canal on both axial and sagittal CT images. Thanks to optimized imaging technique and a good contrast-to-noise ratio. In MIBG SPECT CT images, we can see intense tracer uptake into soft tissue masses, one in the right paraspinal region and another one in the left suprarenal region. In addition, you can see multiple tracer uptake along the axial and some appendicular skeleton that the CT seen only the lytic lesion here and here. This highlights how important MIBG is in detecting osteomedullary metastasis, as it can identify marrow disease that may not be visible on CT alone. Now, move on to the staging, with a focus on IDRF. Nowadays, we use the International Neuroblastoma Risk Group Staging System, or INRGSS, introduced in 2009. This stage has 4 stages, L1 and L2 for local regional disease and M and MS for metastatic disease. Stage L1 tumors are confined and do not involve vital structures, while stage L2 tumors are associated with image-defined risk factors, or IDRFs. I take a closer look for what IDRF is and why they are important. IDRFs are used only for staging primary tumor and indicate potential risk of surgical complications due to involvement of critical structures. However, they do not a contraindication to surgery. Clear reporting is essential for helping the surgeons assess potential risk and determine whether complete tumor removal is possible, even in stage M disease. We recommend reporting for pre-treatment staging and pre-surgical planning at a minimum. IDRF have 3 key assessments: body compartments, descriptive terms of tumor relationships, and vital structures. I'll begin with body compartments, which can be either single or multiple. A single body compartment means the tumor is confined to one anatomic region, such as neck, chest, pelvis, or abdomen. In some cases, like pelvic tumor with contiguous or non-contiguous inguinal lymph nodes, it's still classified as single. In this chest CT of a neuroblastoma patient, show a single body compartment tumor in the chest. This considered IDRF negative. Now, let's focus on what defines multiple body compartments. A tumor is defined as multiple body compartments when it extends ipsilaterally across more than one anatomic region, such as from the chest into the abdomen or from the abdomen into the pelvis. Recognize this is important because it can impact surgical planning and staging. This abdominal CT of another neuroblastoma patient shows a large retroperitoneal tumor that extends from the upper abdomen into the pelvis. Because it causes compartments, so this is considered IDRF positive, not M disease, indicating a higher risk for surgery. Now, I'll move on to the second IDRF assessment, the term to describe the relationship between the primary tumor and vital structures. The term related to IDRF negative, including separation and contact. First term, separation, is used when the tumor remains distinct from neighboring vital structure with a clear plane visible in between. These CT images, you can see a clear fat plane between the suprarenal tumor and the nearby kidney. Another term is contact. where the tumor touches adjacent structure without a clear plane. For example, this CT scan shows a suprarenal tumor in contact with a kidney without fat plane separation. When vessels are involved, this means the tumor is in contact with the artery with less than 50% of its circumference, or in contact with a vein with flattened lumen and still seen flattened lumen with still seen pattern of the venous lumen. Moving forward, I'll highlight the term related to IDRF positive, including encasement, completion, infiltration, and invasion. The first term is encasement, where the tumor is surrounded by neighboring structures. This includes situations that the artery is encased more than 50%, like here and here, and the vein is flattened with no visible lumen, like here and here. The next term is completion, which applies only for the main airways like a trachea or main bronchi. It refers to a reduced airway short axis while in contact with the tumor. For example, this is a calcified mediastinal tumor in contact with right main bronchus with luminal narrowing. The other term is infiltration, which applies to vital structure other than vessel. It means the margin between the tumor and affected structure are poorly defined. As you can see, this is a left pararenal soft tissue tumor infiltrating kidney with left hydronephrosis. The last term I'd like to cover is invasion, which applies only to the renal pedicle. This is a left suprarenal tumor in contact with left renal vein, even though it doesn't meet the criteria for encasement. The final IDRF, vital structures, is based on specific anatomic regions, including the neck, cervicothoracic junction, chest, thoraco-abdominal junction, abdomen, and pelvis. For each region, I'll highlight the key anatomic structures, evaluate the extent of the tumor, and determine the IDRF status and corresponding stage. Let's begin with the neck region. The green box on the left side displays a list of vital structure in each anatomic region, or highlight this structure that tumor is related to. For example, this case, the child has a soft tissue tumor in the left side of the neck. The tumor extends to the infiltrating to the skull base and compressing trachea. So the tumor is summarized within a single body compartment, RDRF positive, and stage L2. Next, let's look at this child with a large ill-defined soft tissue tumor locating on the right lower neck and the upper chest. The tumor infiltrates the brachial plexus root and also encased the critical vessel like here, subclavian carotid, and also vertebral artery. Because of this, the tumor is summarized within multiple body compartment, RDRF positive, and stage L2. Moving forward to our next case, the child has a large mediastinal tumor compressing right main bronchus. So the tumor is a single body compartment, RDRF positive, and stage L2. Now, let's shift our attention to the next patient. The child has a large ill-defined soft tissue tumor spanning from the lower chest to thoraco-abdominal junction and the abdomen. The tumor infiltrates the left T9 to T12 costal vertebral junction, where the artery of Adam-Kiewicz is located. The involvement is raising concern about possible spinal cord ischemia after surgery. At the thoraco-abdominal junction, the tumor also completely encases the aorta and infiltrates the diaphragm. This tumor also further extend down into the abdomen and encasing mesenteric root and infiltrating multiple critical structures like portal hepatis, liver, kidney, pancreatic duodenal block. Like here, due to extensive involvement across multiple body compartments, this tumor is clearly RDRF positive at stage L2. Let's look another example. This patient has a large pubic tumor that extends beyond this line that lie from the ischial spine to the ipsilateral sacral margin. The tumor is extending into through the greater neuroforamina into the gluteal region. This finding is categorized as single body compartment RDRF positive and stage L2. Next, our focus on spatial location. The tumor with, the image is lost. Okay, the tumor with interspinal extension that require specific consideration for RDRF. Let's look at another patient. This patient has a pubic neuroblastoma that mentioned earlier. This tumor also spread into the sacral hole and also into the dural cul-de-sac. That's not considered IDRF positive because it doesn't involve spinal cord. Finally, when it comes to RDRF, it's important to report multifocal primary tumors, pleural effusion, and ascites, that these are not IDRFs themselves. For example, this patient has a pathological proven two primary tumor here and here. Due to the different tumor differentiations from the multifocality of this tumor, these are not considered IDRF. Now, let's move on to metastatic disease. Stage M means cancer has spread to distant sites like a bone marrow, or other organs. Stage MS, on the other hand, apply only for infants under 18 months, where the cancer limited spread to the skin, liver, and bone marrow. In this MIBG SPECT-CT images, you can see multiple foci of tracer uptake in the primary tumor and also the skeleton. This is considered adrenal neuroblastoma with osteomedullary metastasis. The child has stage M disease. Another patient, a 1-month-old boy, presented with rapid progressive marked abdominal distension. This ultrasound image shows a right suprarenal tumor and hepatomegaly with multiple liver masses. CT and MIBG images confirm that infant had right adrenal neuroblastoma with diffuse liver metastasis, classified as stage MS. After we cover staging, let's move on to the next step, restratification. Staging tells us where the tumor is, but restratification helps guide treatment decision by assessing patients' overall prognosis. I will introduce the International Neuroblastoma Risk Group, or INRG classification, that classify pre-treatment risk into 4 groups: very low, low, intermediate, and high risk. With risk stratification defined, let's now look at this impact on prognosis. As you can see from this table, each risk has different prognosis. You can see a fewer half of the patient in the high risk group here only achieve 5-year event-free survival. Now, let's turn our attention to the response assessment. In Thailand, pre-treatment risk classification was modified by Thai Pediatric Oncology Group or Thai POG, better suit our patients. It divides patients into 4 groups, but use a bit different terms, including low, very low, low standard, and high risk. According to the mentioned risk group, Thai POG recommends 3 treatment plans, 1 for very low and low group, 1 for standard risk, and 1 for high risk. For each treatment scheme, all use this result to emphasize when the imaging and marrow re-evaluation should be performed during treatment and post-treatment remission. The treatment plan for very low to low risk group depends on whether it's stage MS or non-MS. For stage MS, chemotherapy may recommend that only for children with large tumor burden or clinical complication. For non-MS, surgery is a primary treatment for all patients, followed by selective chemotherapy in those with significant tumor residue. Standard risk group, the patient will start with chemotherapy, followed by surgery if feasible. For the high risk group, children will start with chemotherapy, followed by surgery and stem cell transplantation if eligible. If not, they will receive intensive chemotherapy and undergo surgery. All patients will receive local irradiation and retinoic acid treatment afterwards. Some order prefer using CT for pre-surgical planning and use MRI for post-treatment evaluation. I move on to response assessment. It means challenging due to complexity of treatment. And now we use the new international neuroblastoma response criteria to evaluate how the tumor is changing. Guided by RECIST, the key concept of this criteria focus on using cross-sectional imaging for measurable soft tissue disease, functional imaging for non-measurable bone and marrow disease, and minimize the use of light-sensitive modalities like bone scan and catecholamine level. RECIST divides the criteria into assessment for primary tumors and metastatic disease. It evaluates size changes in primary tumor and functional alterations, especially through the MIBG scoring system for metastatic disease. Based on the patient response, the outcome is categorized as complete response, partial response, progressive disease, and stable disease. The overall response is determined by combining results from both primary tumors and metastatic disease. If all sides show complete remission, the overall response is complete. If at least one side shows partial or complete response without progression, it's considered partial or minimal response. If all sides remain stable, it's stable disease. If any side shows progression, it's progressive disease. For example, this is a 3-year-old child with stage M neuroblastoma. The CT image shows a posterior mediastinal soft tissue tumor encasing aorta. And the MIBG reveals a tracer uptake at the primary tumor and also left proximal humerus that considering bone metastasis, which is confirmed by the bone scan. Based on Thai POG classification, this patient would fall into high-risk pre-treatment group. This is a treatment timeline along with the response assessment. Firstly, in March 2021, the patient had a mediastinal neuroblastoma with bone metastasis with a Curie score of 4. During chemotherapy in July 2021, the patient performed a functional scan and showed Curie score of 1 due to resolution of metastatic disease. After that, when chemotherapy and surgery were complete, the primary tumor is partial response and the metastasis remain remission. So the overall response is partial. And finally, in May 2023, during surveillance, the primary tumor is still stable and the metastasis still in remission, so the overall response is minimal. Now, shifting our focus to the final topic, how important to follow-up imaging is. Follow-up is an essential part of long-term management and monitoring to ensure the best possible clinical outcomes. Surveillance imaging alongside clinical assessment is key in the early detection of the tumor recurrence and treatment-related complications. Since recurrence more often occurs within 2 years of a treatment, follow-up imaging is more frequent initially and may decrease over time if no abnormalities are detected. Due to the lack of routine consensus, the timing of surveillance varies depending on individualists and treatment protocols. In conclusion, the integration of imaging modalities, risk assessment tools, and response criteria is essential for accurate diagnosis, personalized treatment planning, and effective monitoring of neuroblastoma. Thank you for your attention.